afternoon, good evening, everyone that's joining us today. We are excited to kickstart this webinar. I am Varisha from Abbott, and I'm going to be your moderator for this program. Our topic today will focus on the MitraClip clip design, case strategy, and new evidence. Our first speaker today is going to be Dr. Adam Greenbaum. He is an associate professor of medicine and co-director of the Emory Structural Heart and Valve Center at the Emory School of Medicine. Before joining Emory, he served at Henry Ford Heart and Vascular Institute in Detroit, Michigan for the past 19 years. Dr. Greenbaum has dedicated his career to advancing medicine through clinical research, putting his leading-edge ideas into practice through patient care, and teaching future generations of doctors through resident and fellow education. He's obviously received numerous patient care and teaching awards and is recognized as a clinical expert in the field of structural heart disease. He's board certified in general and interventional cardiology and is a fellow of the American College of Cardiology, the American Heart Association, and the Society for Cardiovascular Angiography and Interventions. Our second speaker today is Dr. Peter Fail. Dr. Fail is the co-director of the Structural Heart Program at Terrebonne General Medical Center and works closely alongside area cardiovascular surgeons as part of a comprehensive heart team to perform interventional procedures for structural defects and complex aortic disorders. Additionally, Dr. Fail has served as the principal investigator and sub-investigator for numerous research trials, piloting cutting-edge innovative research devices to treat a multitude of conditions in the structural heart arena. He's also a fellow of the American College of Cardiology, the American College of Chest Physicians, the American College of Physicians, and the Society for Cardiac Angiography and Interventions. He's a member of the American Medical Association, the International Society of Endovascular Specialists, Society for Vascular Medicine, and the Louisiana State Medical Society. He has written and co-authored numerous research papers and abstracts, several of which are considered landmark. And in 2015, 2016, Dr. Fail was named as the Best Doctors in America list, showing his expertise in the proving exceptional patient care. Now, a couple of housekeeping items for those of you that are joining us. This meeting is going to be recorded and will be available on our website to view at a later time. We do have dedicated time for Q&A at the end of the webinar. Please add your questions through the chat or Q&A section, and we will address those after the presentation. We hope you have a great webinar experience. And with that, I'm going to hand it over to Dr. Greenbaum, who's going to be our first speaker for today.
Well, thanks for the introduction. It's an honor to be here. What I would like to do today is not really spend a lot of time on outcomes data, but maybe relay to everybody how I look at this clip, how it was designed, and knowing those details, how it might impact the choice of clip that I use and hopefully better outcomes knowing it. So we're going to try and spend 10 minutes looking at certain features of this clip to take away some of the mystery. I think everybody knows now that we essentially have 4 clips to choose from, right? We have NTs, got an NT and an XT, and then we got Ws, right? We got 2 widths and 2 heights. I want you to pay attention to 2 things. So if you look at the difference in the height between the NT and the XT, right, it's 15 and 18. So there's 3 more millimeters, and that'll come into play in a minute here. Now, when you open those clips, because of the length to 120 degrees, which is the grasping angle, right, because that's what the grippers will drop down to, you will get more reach with the XT, right? You get 5 more millimeters of reach at 120 degrees from 17 to 22. And on the ventricular edge, right, if you measure on the ventricular side, you measure 12 millimeters instead of 9 millimeters. So those are the differences in the clips. I want you to keep those numbers in mind because we're gonna revisit them in a second. So go to the next slide. So let's look at the gripper element for a minute and how the clip closes. This is a video of double thickness silicone that's simulating a leaflet and the gripper being dropped and the clip being closed. If you look at how the clip closes, you can see that depending on how thick the leaflet is will determine how far to the crux of the clip you can get. So if you can get all the way down to the crux on an XT or an XTW, even though it measured 12 on the ventricular side, on the atrial side where the leaflet is, you're getting about 10, okay, when you grasp and when you close. But keep in mind, if your leaflet is thick, you may not be able to get all the way down to the crux. So when I do a procedure, I know I can get about 9 millimeters of leaflet into an XT or an XTW. And keep in mind that we're not showing the graph here, but for an NT, it's 6. So keep those 6 and 9, keep those numbers in mind because that's how much leaflet you can get into the clip. Now the gripper elements, right, are angled towards the leaflet. They're designed to go in at a depth of 0.3. So this issue about, by the way, am I making holes in the leaflet? Am I perforating the leaflet with the gripper elements? The answer is no, and I'll show that to you in a second. But what I want you to concentrate on is the right side of this slide, which is each one of the gripper elements supplies force and tension on the leaflet. So the gripper elements are evenly spaced, but I want you to notice that the most force that you get, the most tension that's created are the gripper elements that are closest to the crux of the clip. So if you normalize the pounds of force to 0.1 and you call that 100%, you do get tension throughout, but you get less of it. So the take-home message here is you do want to get leaflet all the way down to the crux if you can for best securement. The other point to keep in mind is, for instance, if you choose an XT clip and you only have a posterior leaflet that's, let's say, 6 millimeters, you're not going to get that leaflet down into the crux. And so you don't have the same securement that you would have because you're missing those elements that give you the most amount of force. Go to the next slide. If you look at pathology specimens and you look at average leaflet thickness in the body and at the edge, it is clearly over 0.3. So opening and closing the clip many times should not result in perforation of the leaflet. Now, tearing is a different story. We're going to get to that in a minute, but I just want you to understand that you can open and close the gripper element many times and you should not have any issues with any holes in the leaflet. Next slide. Now, for the tearing aspect, if you think about it, when I showed you the differences in the lengths between the NT and the XT, keep in mind that when you pull that clip up, right, you're pulling it all the way up to the crux. So the additional 3 millimeters of length is on the atrial side. So you're pulling up to the same amount, but you have a longer clip. So when you close that clip and you have that 3 extra millimeters, those 3 extra millimeters are atrial and are pulling the leaflet up into the atrium. So when I choose XTs, XTWs, and I deploy them, as I close the clip, I drop down a millimeter, close the clip, drop down a millimeter, close the clip. So in this iterative motion of those two things, then I'm not pulling the leaflet so taut and so atrial as to cause tear. And what you can see is with that knowledge and with that technique and the Expand G4 registry, you can see very, very few leaflet tears these days. Next slide. To also know the difference in these clips in terms of how much reduction in regurgitation you get, if you build a model and you allow the model to have severe regurgitation at baseline with a regurgitant volume over 80, and then you implant each one of these clips, starting with the NT, going to the XD, going to the NTW, you can see sort of this linear improvement or greater reduction as you move to the bigger clip and then to the wide clips. But the best reduction, of course, with the wide clips, and we're going to talk about, therefore, that's why that's the first clip that I choose, is almost always a W, either the NT or the XT. Next slide. The other thing you're accomplishing with the clip, in addition to improved leaflet coaptation is you actually are reducing the AP dimension. If you look at 3D models based on CTs and real world data on patients who underwent clip and then reconstructed their CTs, you can see a clear drop in the AP dimension by pulling. So you're not just pulling leaflets, but you're actually reducing the annulus. And I just want you to know that this study was done with NT clips. So you don't need an XT to necessarily accomplish this. Both will do it. Next slide. So if you look with improvements in technology to the additional clip sizes and with improvements in technique, you ought to be able to get a really, really nice reduction in MR in over 90% of your patients. Next slide. So what about cases, and go on to the next slide. What about those cases that aren't what I would call ideal anatomy for clip? So what we're talking about is patients that either you think are at risk of stenosis with the clip or they're at risk of an insufficient result. So we can clearly see good reduction in MR in what you consider the TEER suitable patients. This was the EXPAND G4 registry. But if you then start to look at patients who are either at risk of stenosis or at risk of an inadequate result. Now, the patients at risk of stenosis were ones that had a ring in place, a surgical ring. They had calcified leaflets, calcified annulus, thick leaflets, or calculated valve area of 3.5 or less at the beginning. Those people are at risk of stenosis. And they got nice results in that registry despite that risk of stenosis. But I will tell you that between 60 and 70% of the patients got NT and XT clips, right? Those were the thin versions. If you look at the group who was at risk for an inadequate reduction in MR, these were really restricted posterior leaflets. These were wide gaps. These were broad jets. Again, also a very nice reduction in 30 days and between 60 and 70%. So 2/3 of those patients got the wide clips. So they got NTWs and XTWs. So different clips were chosen for different anatomy, but with almost equal and very, very nice results outside of the ideal clip. And this came, by the way, at no significant increased risk in gradient. So I want you to understand that there is this fear that choosing the wide clips is going to significantly cause increased gradients. But in actuality, when you look at studies, and in my experience, I just don't see it. So I think you can safely take the NTW and the XTW as your first clip and see if you can get, because again, remember the right side of that graph a few slides ago where you get the most reduction in MR from the Ws. So without really a significant increased risk of gradient, I like the NTW and the XTW. And again, only 2/3 of the patients, there's still a third of the patients received wide clips, even in that group that was at risk for stenosis. So my clips of choice, right? My favorite clip is the NTW for my initial attempt. I think that you can still get that reduction in AP dimension with the NTW. I think you get the second best, reduction in MR if you look at that graph. And I think it allows for nice anatomic leaflet motion still. Now, if there's a leaflet, posterior leaflet length that's over 9 millimeters, now you can get an XDW and you can get all the leaflet in there and get to all the friction elements. But it doesn't mean you have to use that clip. It just means that now you'll at least get the distributed force over throughout the clip. So I'll often still take an NTW even if the posterior leaflet is over 9. But keep in mind that if you measure a baseline leaflet of 17 or 20, your posterior leaflet, and you put, whether you put 6 or 9 in, if there's motion in that posterior leaflet, you're going to still see motion of your clip. That doesn't mean that you have inadequate amount of leaflet tissue in there. It just means that that's all you can get in there. And trying to optimize further. So if you had 20 to start, and now you can measure, 13 left, and there's still some motion, optimizing any further is not going to do you any good. All you're doing is crinkling up the leaflet inside the clip. Now, for second and third clips, I tend to then go to the NT or the NTW because I find that once the first clip reduces that AP dimension, that I don't need the XT or the XTW anymore. I use plenty of NTWs, and what you can see is I'm not all that far off from the registry. There's probably more XTW used as a first clip than I do personally, but if you look at the second clip, right, you start to see more NTs. Again, I would my personal experience is less XTs, but you can certainly do it. And then even for the third clip, you could still see NTWs being used 10% of the time. But I think at that point, a lot of people are only need an NT for that slight further reduction with the third clip. Next slide. So if you look at it and take it in summary, what the clips do is they restore that vertical coaptation and they reduce the annulus. The best clips in terms of MR reduction are the Ws. If you're going to choose an XTW, though, you need to get all of the leaflet in. Otherwise, you don't have as much securement if you're using the XT. So you want to make sure you have 9 millimeters of leaflet in there. You can get an annuloplasty-like effect by that reduction. And both that and the leaflet coaptation and understanding anatomy, choosing the right first clip, choosing the right second clip, I really think you can get meaningful reductions in these people that are durable. So let's go on to a case to illustrate some of this. There's a patient I did recently who came in with some exertional dyspnea, functional mitral regurgitation, relatively preserved ejection fraction, high surgical risk on good guideline-directed medical therapy. Go to the next slide. So what you could see here is baseline significant MR, and interestingly, not all functional MR is straight up. You can see eccentric jet here. If you look over to the right, though, it looks like a pretty reasonable posterior leaflet, not too restricted, and reasonable length. Go to the next slide. If you look in the 3D, it's a relatively broad jet. So to me, that indicates first clip probably going to be a W. Next slide. Baseline gradient, not too high to start, but even if it was higher, with some of that being flow gradient, I would still, with a leak at A2, P2, or slightly medial lateral, be choosing a W to start. Here's us getting the transeptal. It's a little thick septum there, so you can anticipate having some trouble crossing. You know, here we burn across, and then this patient, although I'm not showing it, we did balloon it with a coronary balloon to make room for our clip delivery system. When you get the clip delivery system in, right here I am rotating posterior and anterior. You can see how you gain height going posterior. I'm just looking at how much height I have. The other thing that I like to do in this view is as I line up the clip, I like to see, am I exactly perpendicular to the annular plane? And so as I'm going back and forth here, I'm trying to decide that. Next slide. We chose an XTW in this case because of the broad jet, trying to get the biggest reduction we could. If you look at the slide on the left, I would argue that that clip is a little vertical to me. It's a little too stood up. I like my clips for functional cases to be at most perpendicular. I even like them to be a little of what we call an aorta hugger or lie down a little bit more. So what I actually do here is I put some minus on the guide, on the clip delivery system, right, which will lay down the clip a little bit more. And you can see on the right that we are now better perpendicular to the annular plane. And I'll even take it, the reason I like it even a little bit more of an aorta hugger is when I come under and I sweep under that posterior leaflet, I want to make sure that I don't fold the leaflet. So I want to get way down underneath. I want to come posterior, and I want to unfold the restricted posterior leaflet in a lot of these functional cases. Next slide. So when I have the clip laid down in this case, I look, make sure that I'm over where I think the jet is. There's obviously respiratory variation here that might move the clip, you know, leftward and rightward, in and out as they breathe. If you want to do a breath hold, you can. I usually choose to not breath hold if I'm simultaneously grabbing, but if I go to independent graspers, I will breath hold so that I don't wind up accidentally grabbing different parts of the leaflet. Next slide. Here, I'll come under the leaflet with the clip. Usually, you're going to have better luck grabbing the anterior leaflet first because it's longer. But sometimes the posterior leaflet's so restricted that I'll still try and grab that one first so I can get under the clip. I can get under the posterior leaflet. I swing posteriorly. I lock that one down, so I drop that grasper, and then I try and push the clip in to see if I can get under the anterior leaflet. And a lot of times you can't because the anterior leaflet is longer. So I let go of the posterior. I then go down into the ventricle, and now I grab the anterior. Right? If you grab too much anterior, you may have a hard time getting back under the posterior. But if you grab enough of it and you don't have too much of it, now I should be able to push down, then swing posterior, wait for the right time in the cardiac cycle to get under the posterior leaflet, and then pull up. So go to the next slide. Once I have the posterior leaflet, which you can see on the left here, if it's a restricted posterior leaflet, I may close the clip a little before I drop the gripper to sort of scoop more of the leaflet so that I can then get farther posterior and then drop the gripper, which we go to do. And then I look for MR reduction. Next slide. So here, interestingly, we thought we got a great reduction, and then we let the clip go. And now I see an eccentric jet coming from the medial side still, even though I'm medial of A2P2. If I see an eccentric jet like that, I usually fix those. That tells me that we've probably twisted something in a little bit of a strange manner. So we're going to go in with another clip here. I don't need the long clip now because I've reduced the AP dimension with the XT. So this is actually an NT. I like to bring my camera. I do all my MitraClip work with the camera so that the clip is perpendicular so that I know that I am straight and that I stay straight. Right on a breath hold, we drop the NT below the other clip. We open it up more ventricular to the one that's in. Next slide. And now we pull back right next to it. And you can see how much closer the leaflets are here, so no need to use the XT. We drop the grippers, close the clip. Next slide. And now you can see that we've taken care of that eccentric jet that was just on the medial side. So to me, this is a really nice result for a functional MR in a valve that looks pretty grungy to me at the start. Next slide. And there's our final gradient and final pulmonary veins. Next slide. With that, I'm going to hand it over to Peter to continue on, and then we'll chat later.
Adam, great case. Let me see if I got this right here. I hope this is right, Awisha. Am I seeing my case okay?
I am not. I'm only able to see your Zoom event screen, not your slides.
Let me see what I got here. Hold on. I'm afraid to kick this out that I'll knock you out completely. All right, let me find out where I went to. How about this?
I can only see your yeah, I can see your slides now. Perfect.
All right.
Yep, that does.
I love technology. So I'm going to talk a little bit about the clip design, kind of go through some of the aspects of it and what makes it important, and then follow up with a case. Adam had already showed this slide a little bit about being able to reducing of the AP dimension, and how do we emulate sort of the Alfieri stitch, or recapitulate the Alfieri stitch. Remember, when you look at Alfieri's paper, he had a lot of annuloplasty designed into this procedure, which that was part of the argument early, that when you were doing a edge-to-edge repair, you weren't providing that. But realistically, when we do these procedures, we are doing sort of an annuloplasty where we're able to reduce the AP dimensions. And so how do we improve this leaflet coaptation and support the annulus? Part of it is the way that the clip was built. When you look at the whole design of the clip, this alloy, if you will, kind of a super alloy, really is what brings this clip together. And not only is the clip arms, but also the clip itself, or the lock itself. This differentiates a little bit from the Pascal device, and utilizing a different material. If you look at L-Jaloy, it's really a magnitude greater than some of the metals that are out there with other devices, such as the 316L stainless steel, nitinol, tantalum. Other devices that we've used in the past for other things have not done so well. Now, the original, when, eValve was being sort of built or being thought of, nitinol was sort of the go-to metal, if you will. And it really had a whole host of problems. In animal studies, it showed incomplete healing. There was straining, if you remember, early stent studies in SFAs showed increasing fractures. So really abandoned fairly quickly for L-Jaloy. It showed really controlling the stability of the leaflet coaptation, nice tissue coaptation, if you will, improved strength, helps healing, and became eco-friendly. One of the nice parts about that is that you can see really tissue bridges in the early, as early as 30 days. If you go back and look at this polyester cover, you're going to get some ingrowth of tissue fairly rapidly, which assists you in reducing the MR even further. Now, I was kind of hoping that I could get a video of this, but the Abbott people told me that the only thing you would hear is buzzing. So apparently 600 million heartbeats in a short period of time. It doesn't show a lot of movement. But what's interesting to see is that they actually put a strain on this locked clip and showed 15 years worth of pulling at the worst case scenario, and showed that there was absolutely no change, no lock, no issues, where actually the clip itself was dysfunctional. So that's somewhat reassuring that when you are leaving a clip, that you don't have to worry about coming back years later, that the clip has opened, that it holds itself at 15 years. Now that stability basically provides, this is the COAP study, and shows that we're able to reduce that diastolic and systolic end volumes, if you will. Remember that just recently, Greg Stone published the 5-year data that showed very similar results, where we really show that the volumes have decreased over a period of time compared to guideline-directed medical therapy. If we look at the 5-year durability, remember that the Everest 2 showed all MR less than 2, and whether we do primary or secondary MR at COAP, you can see that we're showing a 5-year durability. It really is pretty flat. Now, remember in Everest 2 that we were happy originally with +2 MR. If we got our patients to +2 MR, that was really our goal. We were happier if we could get them less than that, but if +2 or less actually met the criteria. Now, Paul Siraj and Saibakar have shown that 1 is better than 2. And I think in today's, mitral valve intervention, that's what we're all striving for. We want to try to get that patient to trace 1 MR as much as possible. And that basically offers a mortality benefit and hospitalization further on down the road. So that's going to be important, that we really strive to achieve the least MR as possible. In the, as I said earlier, Everest 2, we were happy with, +2, and that's why you see the lower numbers at 39, 37, 31%. But as we have expand G4 in the later iterations, you're now seeing that +1 or less is achievable in 95% of those cases. Let's go through a case example, very similar to Adam's. This is a 64-year-old female, high SDS score, guideline-directed medical therapy, and basically the surgeons turned her down. She had significant MR, preserved ejection fraction, degenerative in nature. My imager put together a lot of these slides. You can tell that pretty quickly. He loves to take pictures. But you can see fairly significant MR, central jet, almost straight up, but you see the leaflets are a little bit thickened. If you look at the next thing that we're looking at is going to be the size of the valve. And this is always, my imager will tell me that I can drive a Volkswagen through that valve. And that's always reassuring when you see a lot of area that you have a better chance of less gradient. Now the gradient starting off started at 1 millimeter, obviously MR related, with pulmonary vein reversal. If there's one thing I will say to fellows and to new implanters, spend time getting a very, very good transeptal. it behooves you to really get that height, depending on your functional versus primary, to really get a good septal. And this one, we see we're at 4.9 right here. And this sort of had a little bit of a dive. We were happy with that. As Adam said, you know, the nice thing to do is to try to make sure that you're perpendicular with the annulus. And I think if you look at both of these, both the right and left-hand pictures, you can see we're pretty straight up and down. We were kind of happy with that. And obviously, the thing to do is to do the trajectory and make sure that you like the trajectory, because as it goes further down in the LV, if you're off just a little bit, you'll be further off as you get down. And then, of course, the old, invariably when you put a clip in, you're never, A2, P2, you're always off to the angle. Remember that as you try to change, you're going to change from here where we are a little bit more lateral. And as we actually got a little bit more perpendicular to the line of coaptation, we went a little bit medial. And keep that in mind as you do that you're going to see some movement, not only in the changing the clipped or orientation, but also changing the trajectory, if you will. It's always nice when you see the clip open like that. You can see both leaflets. You can then see the grippers drop, and you can see that you start to see the grippers bounce. I'm going to get this one. There we go. To play. There you go. It's nice to see those grippers bouncing, that reassuring. And then you can also look that you try to do a little bit more what we call optimizing. There's still a little bit more posterior leaflet there on the picture on the right. So I think you can always try to say maybe open up that posterior, lift the posterior gripper, move a little bit more posterior and grab a little bit more for a little bit optimization. We were happy with that. We did some color here, still a little bit. Now, what's missing in this is the conversation between you and your imager of what are you going to do? Do you want to go try to go a little bit more lateral, which we did, and we opened up a little bit of a mitral jet, a medial jet. We then came back and said, we're going to probably wind up being 2 clips here. We have somewhat been surprised sometimes when you can go right down the middle of A2, P2 and get a really nice reduction. Sometimes you look at those and you're going to wind up being a second clip. In this case, that was the concern. So if you're going to do a second clip or know you're going to do a second clip, it's much easier to go medial to lateral and doing the lateral clip second than come in medial like Adam did with his case. You get a little shadowing. It's not that you can't do it, but it is definitely a little bit more difficult to do. We went ahead and let this clip go, knowing that we were going to come in with a second clip. We released the clip, and then we see this lateral jet. You see a little bit of a jet there in the medial. I think that was more at the clip itself. But seeing here in the on-phos view, you see a lot of that was really mostly unlaterally. Gradients still pretty low, still with pulmonary vein reversal. We took a second clip, and then the question becomes, what's the upside and downside? Are you happy with where you are? Do you increase the gradient? And I think all of us today would say, I'm going to be more happy with reduction of MR and accept whatever gradient I have. Obviously, a 10 millimeter gradient would be unacceptable, but really, if you got 5 or 6, you'd be happy with that. Second clips are typically fairly easy. You've already brought a lot of that tissue together. And then we do the exact same thing as we did before. This one was the first one was an XTW, the second one was an XT. We had a lot of tissue that we were happy with playing with and a big valve. And you can see the MR reduction here after grabbing with the second clip, really able to reduce that to trace 1. Gradient stayed low at 3. Here you go. This will have to release the clip. You can see really pretty dies pretty quickly. So we were happy with this. And then, of course, you have the fancy take with my imager liking his glass views. But I think you got a nice tissue bridge. This is sort of the pre and post here. You can see these as we go through. And I think we got a really, really nice reduction with this case. Lady's done very well since we did this case several months ago. Pulmonary pulmonary's normal, you can see. And that's it. And I think we do any questions there, Awisha.
Thank you so much, Dr. Fail. We do have a couple of questions that have come in. I see Dr. Greenbaum is already on it and has answered a couple of them. I think one of the questions that I've seen And I think, Dr. Greenbaum, you've sort of answered it, but it's sort of how important it is for you to have 4 clip sizes in your practice, and where do you typically see the value of NT and XT clips? And Dr. Greenbaum, you've sort of answered that. Maybe you both can sort of give me your
Sure.
I mean, I think that you are at some point going to use all 4 of them. So I think it's worth stocking them, but I think you probably need less of certain ones. For instance, I think we have numerically the least amount of XTs on our shelf. That isn't to say that I mean, if I put an XTW in and I still thought that there was a large coaptation gap, had the AP dimension didn't reduce that much, my second clip next to it might be an XT, but I don't think I have ever started with an XT as my first clip. I tend to use the NTWs and the NTs as my second clip, depending on how broad the residual jet is. If I'm just trying to tack up a little bit of a missed prolapse because maybe the segment of prolapse was a little bit wider than my first clip, or if there's a little flail left behind, then I'll just take an NT for those. If it's still a broad jet, I'll take an NTW, assuming that we have room to the cords and things like that. So I find that those 3, I use the most NTWs. My second most frequently used clip is an NT, and my third is an XDW. So Peter, is yours different?
Yeah, I tend to go a little bit more different. I tend to use a lot more XTWs. I like to try to get as much leaflet as I can into, and obviously the leaflet, being acceptable to that size. So I look at the posterior leaflet. If I can get a lot of leaflet in there, I like that better. And I think the W kind of spreads that force over a little bit more than the XT. So I tend to go a little bit more W's. The second clip really depends on what I'm left with. If I need to do a second clip, I go through all 4. I'll go through an NT, NTW, XT, XTW, and it really depends on what kind of pathology I'm dealing with. Kind of like what you said. If I've got a small little prolapse I need to take up, I may use an NT or an NTW. If I've got a fairly significant prolapse, I don't think I've reduced the height enough, I'll go back to an XT or XTW. I've done several XTWs, simultaneously just to reduce the height of some of these really nasty looking prolapses.
Sure. I don't think we know the answer completely, but I like when I still see natural motion of the leaflets, and I find that the NTW allows that. Sometimes I find the XTW pulls the leaflets pretty taut, and I just worry that the motion's not natural. So I tend to try an NTW first. If I'm struggling by any means, if I'm 45 minutes in there and I can't get both leaflets, I'm going to move. And rarely I'll say this one needs an XDW right up front. I think there's another question here that's important to address, which is how important are the innermost frictional elements? I think those are really important. That slide that I showed you, you do get friction and you get securement from each of the 6, but the most securement you get are the innermost, which is why probably your rep, if you will tell you, if they notice that you only have the tip of the leaflet in, are probably going to recommend that you optimize that one, that you try and pull it under. Let's say you don't have enough anterior leaflet, you would come anterior first, you would open up the gripper, and then you would come even more anterior and drop it down again, trying to get more in there. Again, you can make those measurements, though. There's only so much you can put in there, but I would try and get to those bottom elements. Remember, I guess the engineer, Chad, can correct me, but the frictional elements on the NT, there's only 4 of them. Is that correct?
Yes, that's correct.
Yeah.
Yes, the innermost frictional elements provide the most force for both designs, though, whether it be the NT,
Sure.
NTW, or the XT, XTW. So that full leaflet insertion is very helpful.
And keep in mind, there's only 4 on the NT, right? So you do want to get to all of them.
You want to get every one of them, yeah. I think that's probably one of the reasons I probably tend to lead to go to XT. But I also it's a posterior leaflet measurement. How much posterior leaflet do you have that you're going to be able to shove in there?
Yeah, I do have another question around the clip sizes. It says, what is your preferred clip size in the commissures? There are 2 sort of questions along that.
Yep.
And then there was one, if you have a cutoff for small mitral valve areas.
Commissioners, I tend to go more NTW, depending on where I tend to be, you know, a smaller clip. I'm worried about cords. And so if I'm out in the commissioners, I'm usually using NT or NTW, probably more closer to NT.
Sure. It's because the issue there for everybody is, by the way, if you're taking an XT or an XTW and you're really in the corners and you drive in and your clip happens to rotate on you, right, and you wrap, you may never get that undone. So I tend to also use the NTs and the NTWs in the corners. The other thing is, and I do this in every case, but when I go in and then you go to your 3D atrial view and your echocardiographer tells you that you're lined up at A2P2, then I move the camera so my clip is sideways. And so it's usually some amount of cranial, maybe some RAO. And then as I'm going into the valve, if I see any tilting, right, then I fix that before I go down. If I tilt, I fix. And that's most important when you're out at the commissures, because once you wrap, you may never get to unwrap. So having the fluoroscopy help you so that you drive in straight in the corners with the smaller clips, I think is the way to go. There also doesn't tend to be as big a coaptation gap out there, right? The annulus is sort of closer together in the corners. You know, as for a valve area, if you start doing your case under, you know, like under 3.5, you're probably
You're
not going to be happy with the gradient. Again, the you know, in the registry of people at risk, you know, for stenosis, they did do cases under 3.5, but you know, I wouldn't go much under that.
Yeah, I remember that Everest 2 had you know, a cutoff of 4, and we've gone down to 3.5. But you're right, you get down to 3.5, and you're starting to worry about, you know, you're going to leave a residual gradient of 8, 9. You know, that's going to be an issue long term for sure. And I really, and it also depends on the individual patient. I mean, if you have an 85-year-old, you know, an 8 mm gradient is probably not going to be a deal breaker as opposed to a 55 or 60-year-old. And so something to think about too as an individual patient.
But just so you know, you're not usually going to get a bad grade. I mean, I showed you the slide that the gradients don't really the gradients are not going up because of the width of your clip. When the gradients go up,
Right.
it's because there's really stiff leaflets, right? And so what you've done is it's the garbage can lid where now you've shut the whole thing down. It was either an all or none thing, that the leaflet's just not pliable, but it's not usually the clip. So I don't have a problem with an NTW in the corner, by the way. And also in the corner, right, you're really not going to get an increased gradient because you're really only shutting down one of the commissures. So don't be afraid to use the NTW unless it looks like, you know, a world of hurt out there with a bunch of cords. But if it looks like there's room, I don't have a problem with an NTW in the corner. I just don't like the XTs in those circumstances.
You know, and I think you also brought up a really good point too, Adam, about doing fluoroscopy, you know, when you advance into the LV. I think that's really, really a smart move, something we've done for a long time too, you know, that you really watch it. And as you see, if you can start to see your clip starting to rotate, especially if you saw the case that I did, you saw that we were definitely a little cockeyed. We had to get credit. What's going to happen is as you go LV, that's going to continue going, and that you're going to have that built up torque, and so you can actually pull back or actually rotate back. So remember, if you're going counter or clockwise, to get your clip in the right co-op pleasure. As you go into LV, you may still go that way. And so it's real nice to go, you know, use that fluoroscopy to help you adjust slowly. And then absolutely, you don't need to go all the way down the LV. You just need to go below that line of coaptation and get the clip just below that.
The other thing that we actually didn't talk about that I do think is another crucial part of this is we talk about this expression of ringing the towel, right? Which is, you know, when you ring a towel, one goes one way, one goes the other, right? That's how you ring the towel. So there's this obligatory relationship that when you go anterior posterior, right, the clip may actually turn, right? So when you come, let's say when you counterclock, right, the clip, right, it wants to bring it anteriorly, so you wind up putting some posterior on the guide. So if you are going anterior and posterior and you are swinging, right, to try and grab leaflets, just so you know, when you make that move, because of that obligatory interaction, the clip may actually counter or clock. So if you're in that perpendicular view, you can see that and you can correct it without having to go back to a 3D en face view, which will just increase the efficiency of your procedure because you won't need to keep checking that you're straight. So understanding that relationship between the two that is always there, I think is helpful. Like there are times that if I'm swinging posteriorly, right, I'm already counterclocking as I do it because I just know that's going to happen as I come back and vice versa, right? So
So
a couple other questions here
Yeah, I've
about
got a couple of questions here. Which pathologies you advise young operators to avoid when starting a program? And then what's your advice for best way for someone to train for clip implantation for practicing physicians who are sort of not doing structural fellowship?
severely restricted posterior leaflets, I would avoid as a young operator. I mean, I think those tend to be a real nightmare. And obviously, if you unfortunately get a Barlow's, I think a Barlow's can be a nightmare also, trying to reduce that volume on both leaflets. Those are the two that I would try to avoid as a new operator or fellow right now coming out.
Yeah, the other thing is early on, right? It's probably even more important to get a nice result, get the patient back to their referring doc feeling better with a good result echocardiographically so they can see and believe in the technology. And so I think if you start early on, it's one thing if you've done a couple of 100 cases and then, you call up a doc and say, look, we tried, but we didn't get as good a reduction as we wanted. At least they've already seen some good cases come back to them. So I think really broad jets across the whole valve, when that anterior leaflet just really looks like a garbage can lid that doesn't have that just doesn't have a lot of pliability to it, probably avoid those early on. Straight up P2 prolapse in a high risk patient is a nice case to start with. Bileaflet prolapse or the combination of a restricted posterior leaflet and a prolapsing anterior leaflet, those are the hardest. So you might want to stay away from those just at the beginning. And then again, as everybody, the cath lab staff sees good results, the rounding team sees good results, the people reading the echo see good results, the referring docs, then you could start to branch out. So that's how I would look at it.
I agree.
All right, there are more questions. So at what gradient do you not favor a second clip? I feel like you sort of answered a little bit, but that was one question.
Look, I'll go 6, 7, 8. I mean, again, this is all dependent on heart rate, obviously. So I'll assume the question is saying at a heart rate of 60. Let's preface it with that. I do think depending on what you're trying to achieve and the age of the patient and what they do on a regular basis, you probably can go a little higher than this cutoff of 5. The cases that I abort, that I basically invert the clip and take it out, when I drop the clip down at A2 P2 and the gradient goes to 11 or 12 because the leaflets are stiff, just so you know, moving that clip slightly one way, slightly the other, it's never going to get it down. Like maybe you'll get it down to 10 or maybe you'll get it down to 9, but those you pretty much can say, look, this is just not leaflet anatomy that's good for an edge-to-edge repair. If you drop the clip down and you got it to 8, then you could say, well, maybe I can move it and I can get it to 6, and when I release it, it'll be down at 5, kind of things like that. So I'm okay in that 6, 7 range. If you're at 5, 6 with the first clip and you still have significant mitral regurgitation and some of the residual gradient is MR, and that putting the second clip in, you're going to knock it down. So I'm not afraid to try and second clip at 5 or 6 with significant MR, because I've gone 1 clip, gradient 6, 2 clips, gradient still 6, 3 clips, gradient still 6. It doesn't have to go up each time because some of it's flow related. But when you get in there and when your gradient's 10, 11 after dropping the first one in, that's not an edge-to-edge repair case.
Yeah, I agree. I think we do the exact same thing.
Great. Any advice for MR due to chordal ruptures?
Surgery.
Those are fair game. I mean,
they're good. They're good edge to edge.
Yeah.
I mean, they usually have a nasty prolapse. They're a little bit more difficult depending on the gap, but usually a chordal rupture is a really good one.
Yeah,
There's a
and
question
then,
here about repeating the transeptal.
yes,
I think that it's a great question. If you wind up too low, a little too low, right? You can go posterior, add a knob, and gain height to do your case. So I'll try and work with that. If I am too high, like sometimes you think you're at 4 and then they weren't showing you, or they were somehow foreshortened in their view, and then all of a sudden you're at 6 or something like that, and I'm sending out a lot of the clip and it's not behaving right, then those times sometimes I'll say, you know what, it's just not worth it. Let me just restick. And if sometimes I've gotten too anterior and then I'm struggling with being able, I like to get that clip perpendicular to the annulus. I like it going in and out straight, so I can do whatever I want. But if I find that because of that I'm too anterior, that I'm putting too much force on the cables, too much AP, too much M, or things like that to correct it, I'll pull back and I'll restick. So if the clip is not behaving or you're struggling, sometimes it's not worth it, because you'll find that the case will just go smoother with the restick.
yeah. I do want to switch gears. There was an earlier question that had come up was, how do you work as a heart team with your heart failure cardiologist for SMR patients?
We do fine. I mean, fortunately, we don't have a big heart failure team. So it seems like a lot of the cardiologists do their own heart failure. So that helps us a little bit. I know that in other centers where heart failure cardiologists tend to be a little bit more siloed, they tend to hold on to their patients a little bit more aggressively. So it does become a little bit more problem from hearsay. I think that's much more seen in like in a big university with a big heart failure. At the end of the day, I think it's going to be who's the dominating force in the cardiology department. If it's the interventionalist, I think you have a chance of making things happen. If it's the heart failure people, it's going to be a struggle. And politics is everything, unfortunately.
If your heart failure team is really focused on medical therapy until the end, and then LVAD transplant, and don't really have edge-to-edge repair in their mindset, then I think it's getting some nice results, sharing those results, and kind of building a relationship with them, explaining that certainly having a clip is not going to change their LVAD transplant status. To back on the question, for someone who's not in training or didn't do a structural fellowship, how does someone in practice get some additional training? To be honest with you, if you take one day and go to a center where somebody to visit another center, you're happy to come to Emory and spend one day with someone who can sort of just go through some of these subtleties and things that can increase the efficiency of your procedure. And why I move the fluoroscopy so that I can just make the procedure shorter. I don't have to go back and forth, things like that. I think you spend one day and get some tips and tricks from someone who's experienced. I think it will help a lot. You don't need to have a dedicated fellowship for this. I didn't have one.
And then there was another repeat question around, you describe gradients. However, are you taking HRBP into account on borderline cases? And are you taking 3D measures of mitral valve areas to make your decision?
Peter, you want to talk? Go ahead.
I don't think I understood the question.
Are we using 3D area instead of just gradient to help? We have not been, because now you're looking at making two areas. Are you talking about NPR on the table? In other words, doing to the two orifices now to see what you get. We have not been doing that. We've still been using gradient, and we sort of sometimes, if I'll try and slow the heart rate down with some metoprolol or something to see what it is at a slower heart rate. There's no black or white on the gradient, by the way. I think you're going to have to play that case by case.
But I think, and I'll be honest with you, I think we've been originally been very fearful of the gradient, and I think in years past, but I think probably over the past several years we've been allowing a 6 or a 7 if we thought we could reduce the MR even further. And so I think that there's some pretty good data out there that says reducing the MR is much more important than the gradient overall. Obviously, there is a cut point when that gradient becomes unacceptable. But I think a gradient of 7 is perfectly fine if you have no MR or trace MR, as opposed to a gradient of 5 with +2.
I think we can probably take one more question because we have 1 minute left. This question is, for difficult cases with leaflet grasp, do you change tidal volume or PEEP to help?
Both. So I've done the change the tidal volume by reducing it and increasing the frequency of breathing, or actually just hold the breath. I mean, it's amazing how long you can ask your anesthesiologist, just watch the sometimes we'll hold it in expiratory, sometimes we'll hold it inspiratory, depending on what the clip is doing compared to the mitral, what I'm trying to conquer. But then we just tell them to hold the breath, and you can hold it for a substantial period of time, believe it or not, before the anesthesiologist says, can we breathe them? So you have a little bit of time. It's not like you have to rush in and grab it right quickly. You've got, you don't have an hour, but you do have some time that you can do the procedure.
And just ask this anesthesiologist to keep the tidal volume as low as what they think is reasonable. And by the way, if you get in there and the left atrial pressures, if they're stable and the pressure's 45, just so you know, when you're struggling, you could always, take the clip out and put that person in the hospital, diurese them for a bit, and bring them back, and you may find that those leaflets are closer together. So some of it depends on opening left atrial pressure.
Right.
Great, we are on time, and I wanted to thank both of our speakers, Dr. Greenbaum and Dr. Fail, for taking the time. I wanted to thank the audience for asking some really, really great questions. And this will be available as a recording for those that are unable to attend or those that wanted to want to watch it again. Any final thoughts, Dr. Greenbaum and Dr. Fail, before we close it out?
Nope. Good luck. I think it is a therapy that you can get really, really nice results with. You just have to think about how the anatomy of the clip matters in terms of its interaction with the patient's anatomy.
That's I'll agree with Adam. I think that what's really nice about the MitraClip, this is really a thinking man's procedure. It's not to minimize how difficult TAVR can be sometimes, but compared to TAVR, it's a valve, whereas the mitral, it's an apparatus, and you have a lot of different choices, and it does take some thought, moving forward. How are you going to fix this patient and help this patient, long term, not just in the lab, but how are they going to do years from now?
Great. And with that, I just wanted to thank everybody for taking the time, and I hope you all have a great rest of your evening. Thank you all.
Thanks, Risha.
Yeah, everybody.